Good afternoon. Welcome, everybody, on this webinar. Fantastic that you join me here this afternoon for this live event. There are about 600 registrations for this event this afternoon, so that's really super. Well, I'm happy, and my team, both of us, we are happy that we can give some live seminars again. So for those of you who follow me, you know that I give a lot of online events, but of course the live seminars, this gives the extra thrill, so to speak. So I'm very happy about that. But nevertheless, I still continue giving once in a while a live webinar because this is also very inspiring. And in the meantime, I see in the chat that I already may welcome people from all over the world. Yeah, Indonesia, Malaysia, Bulgaria, Peru. Hey, fantastic. It's really wonderful to have so many guests from all over the world online. My local or some of my local organization partners asked me to inform you about some live courses which are going to happen in the next weeks and the next months. And as you can see on the screen, where we start with new courses in Poland, also very shortly an interesting spine course in Bulgaria, and we start in Italy also with new events. If you want more information about that, just surf to our website and you will find all the information you need. In the meantime, we have guests from Bhutan, from Germany, also from India, other guests from Bulgaria. Fantastic. Welcome. Well, as usual, I'm broadcasting here from De Haan, a little village along the Belgian coast. I'm broadcasting live because this is not a pre-recorded webinar. This is really a live webinar, so I hope we don't face any technical problems. I'm broadcasting from our International Training Center over here. And also good news on that field. In May, I will have a next mastermind training program over here, worldwide exclusive, just maximum 4 participants. And the program for May is already is fully booked, and that's why I decided to offer another mastermind program in September. And for this mastermind program, there are just 2 seats left. So you also find all the information you need online. Be my guest. And in the meantime, other guests also from Croatia, Venezuela, Slovenia, Montenegro. Fantastic. Okay. So my promise for you today, is I'm going to, mess around a little bit with your brain. Yeah, I'm going to perhaps shock some of you. We're going to see what happens, because when we talk about musculoskeletal medicine and more specifically lumbar spine problems, well, there is quite a lot of controversy. There are quite a lot of views. And what do we do with all of that? Those of you who already know me, then you know that I'm not a fan of artificial hypercomplication. I like to keep things as simple as possible, if it's possible, of course. In the meantime, Alexander from Switzerland, also welcome. Bangladesh is also there. Really? And Jeroen from Belgium. Yeah, great. Great that you joined, Jeroen. Welcome. Yeah, lumbar spine problems. Of course, we all know that we need to look at spine problems from a biopsychosocial perspective. Yes. This afternoon, so we have about one and a half hour together. This afternoon, I'm going to focus a little bit on the bio aspect. And in the meantime, some other guests from Belgium, Tine, together with Natalie, also welcome. And Bolivia is also there, Pakistan. Oh, really fantastic. Okay. But you all know, if a patient has a back problem and he goes to, let's say, 10 different therapists, no matter what therapist, general practitioner, physio, osteopath, chiropractor, whatever, then most likely he comes home with 7 different diagnoses. So that's quite a challenge. Is there some kind of absolute truth? Of course not. There are different interesting truths. But the major challenge is when you try to reach some kind of diagnosis and a therapy plan, of course, then the question is, which tools do we use? And this is a major, I think, this is a major problem in our profession. There are dozens and dozens and dozens of different tests people use in the lumbar spine. If you look at the big manual therapy world, then there's, just pick a choice. There are so many different tests. So that's one little detail. And another little detail is, what do you do with those tests? Yeah? Unfortunately, many of those tests seem to be quite irrelevant. But they still seem to be very popular, but they are irrelevant. And I mentioned that shortly in previous webinars, that sometimes I feel frustrated that I see many other colleagues doing some very complex things, some very complex maneuvers, specific palpation techniques where they feel all kind of hypomobilities and so on and so on. And why am I frustrated? Because I don't feel that. So probably that's my problem. But when I'm honest with myself, I don't feel that. And I'm sure that many of you here in the audience today, there are many of you who also don't feel that. And what is the good news? Well, the good news is many of us, we learn at university or in some other courses, when we let's say deal with lumbar spine patients, that we need to palpate a lot. Just 2 weeks ago or so, I had a spine course in Poland, and I showed a similar slide as the one you see now. And some people were surprised. People said, yeah, but the first thing we learn in our training programs, the first thing is palpation. Well, if I'm going to shock with your brain today, well, this is the first shock. Palpation is the best way to reach an invalid diagnosis. But that's good news. We don't have to lose time with that. Yeah? Anyhow, all the concept of segmental palpation in the spine, more specifically in the lumbar spine, to detect so-called hyper and hypomobilities, well, the validity of this kind of procedures is, let's say, very, very limited. In the meantime, more guests from USA, Estonia, and Uma is asking, can I get a recording of the webinar? Oh, yes, you can get a recording. You can view, all of you, you're going to receive an email when this webinar is finished. And in this email, you're going to have a replay link. And normally, I give you 2 or 3 days time to view the webinar again, or for those who are not able to join here live. But today I do something special. Today your replay link will be valid for 1 week. So during 1 week you can watch the webinar whenever you want. So I hope that helps you. Okay, so when we examine a spine patient, what do we need? Well, if possible, some kind of standardized protocol. If possible, less wishful thinking and less artificial hypercomplication. And again, I'm not talking about the truth. Absolutely not. I like to look at things in an open way. I'm not a very big fan of tunnel vision. I'm not a very big fan of guru methods that you use one specific method to deal with everything. I don't think that's 100% correct. So I like to look in different directions. But whatever method you are using, or whatever approach, make sure you have some kind of standardized approach. And for instance, in our orthopedic medicine training programs, we developed standardized assessment forms for each joint, where you have a specific protocol, inspection of the patient, history of the patient, basic examination, accessory examination, and the whole clinical reasoning process. What you see on the screen is just a little element from this standardized examination protocol. But once again, whatever approach you use, make sure you have a more or less standardized approach. Talking about standardized assessment, well, this book here, it's 156 pages on clinical reasoning, where I explain how you can use this assessment form. You can have it. It's on the website. When you go to cdiax.eu, you just can download it for free. Absolutely no problem, with pleasure. So many of you already did that, but most likely some of you didn't, so you can do so today. So what is going to be the purpose? The purpose is going to be that we are going to collect puzzle pieces. I have the impression when I'm traveling around the world teaching courses that certainly in the physiotherapy world, we are pretty fast happy, or we are too fast happy. When we examine a patient, then we find one positive test. Oh, we have a positive piriformis test. Yay, okay. And the problem is the piriformis syndrome. Don't jump to conclusions too fast. Yeah, we're going to. I always formulate it in such a way. We look at the package. I need some elements from the history. I need some elements from the inspection. I need some elements from the functional examination. We're going to put the puzzle pieces together, and then okay, our clinical reasoning process is starting. And that's exactly what I'm going to do with you this afternoon. We're going to collect some puzzle pieces. Somebody is asking in the chat, please mention the name of the book I just showed. Well, it's easy. Clinical Reasoning in Orthopedic Medicine. Just go to cdiax.eu and you can very easily download it over there. Not only the book, but also many other things. Okay, talking about downloads, I have a challenge for you. Let me share something with you. Okay, so if everything is okay, you should see on the right side of your screen, you should see a PDF file you can download. Just let me know in the chat if everything is okay, if you can see it. Specifically for today, I made a special lumbar spine checklist for you. And what can you do with this checklist? Well, first you download it, of course. And then I suggest that after this webinar today or tomorrow, you take 20 minutes time, focus time, you have a look at this checklist, and based on what I shared with you today, have a look what you can do with this checklist. Yeah, have a look what is the impact on your clinical reasoning. Okay. So that's for later. So everybody sees the file? Yeah. Be my guest to download it. Okay. So everything starts with the beginning. If somebody has back pain, one of your first questions is going to be, where? Yeah, of course. And then, of course, everything is possible, and they can have central back pain, bilateral back pain, gluteal pain, referred pain in the leg. And then there is something some basic thing we have to realize. Soft tissue lesions, they very often give referred pain. And what does that mean? Of course, most of you are already familiar with that, but you know that if a patient has a hip problem, the hip is mainly an L3 structure, so that's going to refer pain somewhere in the L3 dermatome. So where is the patient going to have pain? Well, he has pain in the groin, the anterior aspect of the leg, perhaps also a little bit in the back. That's also possible. Facet joint, sacroiliac joint. For instance, sacroiliac joint, mainly the innervation is S1, S2, S3. So if somebody has a symptomatic sacroiliac problem, then most likely there's going to be pain somewhere in the S1, S2, S3 dermatome. That's important to know because let's imagine that somebody has anterior pain the leg, then my very first idea, just based on the radiation of the pain, is not the sacroiliac joint. Okay, of course, ligaments can also refer pain, and yeah, as you know, nerve roots also. Yeah, but all of those structures are going to refer pain in a segmental way. Yeah, in a certain dermatome or in part of a certain dermatome, not always in the total dermatome. And of course, yeah, basic knowledge, you need to know more or less where are the dermatomes. But there is, of course, a but. If you look at different atlases, you're going to see that there are some discrepancies in dermatomes. And yes, dermatomes are not an exact science. Yeah. There are inter-individual differences, there are intra-individual differences, but more about that a little bit later. So most of the structures, they refer pain in a segmental way. Yeah. Okay. But in the spine, we have some structures who have their own rules, who say, I don't care, I have my own rules. And this is, for instance, the discs and the dura mater. They cause, when there's a problem with dura, they cause multi-segmental pain. What does that mean? Pain in several dermatomes at the same time. And as you can see on that little image, if you look at the lumbar part, actually a lumbar patient can have radiation of pain all over the place. Anterior, posterior, lateral, medial, down the leg, all over the place. And that's interesting to know because somebody who has leg pain doesn't necessarily have a sciatica. What is a sciatica? A lateral disc protrusion with pressure against nerve root. This is not so frequent. This is the minority of the lumbar spine patients. So most of the spine patients who have radiation of pain in the leg don't have a sciatica, but they have multisegmental reference of pain coming from some kind of discodural conflict, or if you want another name, internal derangement. Yeah. There is one strange little thing you can see on the image here, and this is purely empirical. We don't expect referred pain from the dura in the feet. We don't have scientific backup for that. For that little, no, this is at this moment purely empirical. But the fact that the dura is innervated, and not only the dura, but also other structures in a multi-segmental way, yeah, in the meantime, that's very clear. Well, I have some premiere for all of you today. Yesterday, I uploaded some brand new information on our online masterclass, the online toolbox in orthopedic medicine. Some of you already have access to this toolbox. Yeah. For those of you who don't have access yet, well, at the end of this webinar, of course, I'm going to make you a pretty special offer, and I'm going to explain you a little bit more about what is the online masterclass about. But search to orthopedicmedicine.eu, you can already discover some things over there. And yesterday I uploaded 2 new lectures. The latest status on understanding and dealing with pain, really the latest scientific views. It's a lecture of 1 hour and something. And I also put something online about the validity of the dermatomes. Okay. In the meantime, once in a while I have a look, if you allow me, with one eye to the chat, and I see that Patricia is asking, I have a patient that shows in her x-ray that she has spondylosis L4, L5 disc. We tried to treat her in that area, but her main complaint is in her upper back. That sounds very logical to me. I'm going to come back to that later. When I said earlier, palpation is the best way to reach, let's say, a useless diagnosis. Well, looking at medical imaging is the second best way. Cyriax, long time ago, before MRI and so on, he used to say, never take an X-ray, and if you take one, don't look at it. Of course, medical imaging can be very interesting in certain cases, but the fact that you see spondylosis in L4, L5 disc is, for me, a completely irrelevant finding. Yeah? Mostly that's completely asymptomatic. So we have to collect other puzzle pieces. So Patricia, I hope that at the end of the webinar, together with me, you will have discovered some extra puzzle pieces that can help you. Okay, where is your pain? Central pain, bilateral pain, unilateral pain, everything is possible, of course, but keep in mind what I just said earlier. A unilateral structure only causes unilateral pain. This is a general rule in orthopedic medicine. I will repeat it again. A unilateral structure only causes unilateral pain. So facet joints, sacroiliac joints, hip, some muscles, unilateral structures only cause unilateral pain. An internal derangement, a discodural conflict or a discoradicular conflict, but more specifically a discodural conflict, that can cause everything. It could cause central pain, unilateral pain, bilateral pain, multisegmental pain. Everything is possible. And the beauty is following. Let's imagine, let me show you something. I'm going to try something. Yeah, just a moment. Voila. Here I am. Imagine the patient has, I hope you can still hear me, the patient has unilateral paravertebral pain. Okay? He has unilateral paravertebral pain. And we palpate there. And then many patients say, oh, so don't palpate. Don't do that. Don't waste your time with that. But many people with unilateral pain, they automatically think, facet joint. No. Ask one simple question to the patient. Did your pain start there? And then many patients say, well, actually, a few days ago, I felt it here in the middle of my back. But since yesterday, I feel it over here. And what happened with this pain? this pain is gone. So what is that? I love it. This is what we call a shifting pain. And a shifting pain is always a shifting lesion. Yeah, so imagine there's central back pain. Then the patient gets unilateral back pain. Perhaps he gets gluteal pain. And then perhaps pain in the leg. And what happens with the back pain? The back pain disappears. And now he just has leg pain. I love it. This is a shifting pain. And a shifting pain is always a shifting lesion. And Uma is saying in the chat, peripheralization. Yes, you are right. This is an example of peripheralization. We don't like that. But the concept of shifting pain automatically means this must be an internal derangement. This must be a discodural conflict or a discoradicular conflict. Facet joints don't do that. Sacroiliac joints don't do that. Muscles don't do that. Ligaments don't do that. And that's why your history is so super important. Let's imagine the patient has pain in the leg, and then he gets pain in the back. That's also shifting pain. And then it will be centralization. And of course, yeah, centralization is something we like, of course. So, as you know, I live here along the coast. And just before we started this webinar, I was there. The picture you see, and I was just walking over there. I have to see the beach every day. I'm a little bit addicted to the sea. Well, when we talk about mechanical back pain, I'm going to start here with a pretty impressive quote. 90% of mechanical low back pain is in relation to the disc. Whoa. That's a pretty heavy quote. Yeah. This was a hypothesis from Syriacs in the past, but in the meantime, others are also looking in that direction. For instance, Mackenzie is also following such a track. Yeah. When you talk about mechanical low back pain, yeah, you can have this hernia, and you can clearly see on the picture that the annulus is completely broken, and then the nucleus slowly comes out. This is, of course, most likely misery. And this is probably not going to be a patient for us to treat. Probably we are not going to be successful. But what is the good news? The good news is that this kind of patients, they are pretty rare. Mostly you have this kind of patient with some kind of disc bulging, disc protrusion, whatever name you would like to give it. But what's the difference with the previous situation? Well, here the annulus is completely broken. The hydrostatic mechanism of the disc doesn't function anymore. And here the disc is a little bit damaged, but the hydrostatic mechanism is still working. But keep in mind, I come back to medical imaging. Keep in mind when you see that on an MRI, what does that mean? Nothing. That could be symptomatic, but that doesn't have to be symptomatic. So again, we have to collect puzzle pieces. And remember, one of the most important puzzle pieces I just mentioned to you was the shifting pain. Yeah? Or perhaps you have an internal derangement with pressure against the nerve root, and then we have the so-called sciatica. But as I told earlier, sciatica is much less frequent than the discodural conflict. Okay? Good. Of course, your disc can be damaged in different ways, as you can see on this picture. But damage does not necessarily has to result in symptoms. Yeah? It all depends on the innervation of the disc. Does the disc have a good innervation, yes or no? And mostly they don't have such a good innervation. They have innervation, but not all over the disc. But okay, I'm not going to go too much in detail now on that subject. But okay, discs itself could cause pain, but this doesn't happen so often. In the meantime, I go to the question of Ahmed. We see patients with referred pain in the lower limb, but with no pain in the back. Oh, yes, Ahmed. Yes, completely normal. I see that also all the time. Yeah, no problem. Most likely it's going to be multi-segmental pain, so pain in several dermatomes at the same time. That goes together with discodural elements. Okay. For orthopedic medicine, you don't need too much this. You don't need too much your hands. You need more your eyes and your ears. And everything starts with the inspection. How is the patient sitting in your waiting room? How does he stand up? How is he sitting in your clinic while you're doing the history with the patient? How is he dressing, undressing, and dressing? All those things could be useful information. And that's a picture from my clinic here at home. Okay, but what can you see? I don't have a separate, let's say, dressing room for the patient. The white chair you see on the picture and the little black chair, well, that's the space where the patient is undressing and dressing. And at the same time, I'm sitting behind my desk and I'm taking some notes. But with one eye, I can see what is happening. This is super important information. If a patient tells me during the history taking, oh, I have problems with flexion and blah, 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 I have to see that when he takes off his clothes. But even more important, when you talk about spine patients, and more specifically treatment, okay, you can mobilize, manipulate, traction, whatever exercise, but the most important part is the prophylactic part, is the prevention part, is the homework of the patient. And you give him some tips and tricks, yeah? And if the patient is sitting behind the curtain, and you just said to the patient, well, let's say the first week, I would like that you are a little bit more careful with too much flexion, just for the first days, yeah. But if the patient is behind the curtain, 99% of the patients who put on their shoes, what's the first thing they do? Flexion, flexion, flexion. So you can't react. So if I see what is happening, then I can react, and it's easier for me to guide the patient. Shifa asks me in the chat, I saw a patient who had a disc bulge at the level of 4L5, but range of motion are normal, no pain in any moment. Perfectly possible. Yeah, that's one more reason not to look too much at medical imaging. If you would pick 100 people from the street above the age of 45 and you put them all in the MRI, at least 50% of the cases you're going to see disc bulges. And they are not necessarily symptomatic, they are perfectly okay. So we have to be careful with that. So that's the reason why we have to focus so much on more objective information. Okay. We saw how the patient is sitting, standing, walking. But perhaps the patient has some kind of deviation. Perhaps he has a flexion deviation. He's blocked in flexion. And if you ask him to do an extension, it's hopeless. He's completely blocked. Yeah? Or perhaps he has a lateral deviation. And then the question is it relevant or is it not relevant? If you're talking about a scoliosis, that's also kind of lateral deviation, but with a rotational component. To be honest, for me, a scoliosis is not relevant. I'm not talking about major scoliosis you see in children and young adults. No. I'm talking about a minor scoliosis, which you sometimes see in adult people. Mostly this is completely completely irrelevant. Yeah? In the meantime, I'm going to have a look at the chat again. Somebody's asking L4S1 posterior disc bulge with referred pain to the posterior aspect of the right knee. Right side of the back hurts more, no pain on flexion or extension, mild scoliosis present as well. Okay, also perfectly possible. If you just stick with us in this webinar, I'm going to talk a little bit about functional examination, and there I'm going to give you a tip, a trick, which you can use to see whether this is symptomatic, yes or no. So just a moment, okay? What is interesting me more is, for instance, this patient has a flexion deviation. And you can also see on the left picture that she has a slight lateral deviation towards the right. This patient has a beautiful lateral deviation towards the right. I have another one for you over here. Yeah, this is beautiful. Yeah, okay. For us, this is beautiful. For the patient, this is not necessarily beautiful. But when you see such kind of lateral deviation, well, you have a very, very big chance that this is an internal derangement. And not only an internal derangement, but a bigger one. So that will mean that we will need more time to reduce that. We will need more treatments to, let's say, solve this problem. Yeah, a lateral deviation or a lateral shift. Actually, yeah, I love that. I love that very much. And we can play a little bit with this lateral deviation. Let's imagine somebody is deviating towards the right and he has pain on the left side. Okay. Or he deviates towards the right and he has pain on the right side. Both options are possible. Actually, this is just related to, let's say, the position and the size of the internal derangement, which I can't objectivate that. I don't have this information, but it is related to the internal derangement. The body is always looking for, let's say, the best escape position. A patient with a lateral deviation feels better in this position. This is an antalgic position for him. Sometimes you also find what we call an alternating deviation. Let's imagine somebody has a deviation to the right and he's doing a flexion. And at the end of the flexion, poof, he has a deviation to the left. Hey, fantastic. This is just a discodural pressure game, so to speak. So if you see those things, think of an internal derangement. Somebody's asking in the chat, the deviation, is it called a shift? Yes, it's a lateral deviation or a lateral shift. In the meantime, I'm going to look at something else in the chat. Shifa is saying, I saw a patient who had a history of a fall, and after that he ignored it, but within a few weeks he lost his bowel and bladder movement, and now he has paralysis, totally bedridden. Is there any chance of recovery? Whoa, this is a very heavy story. I can't predict that. I don't know. I don't know how much damage he has in his spinal cord or other nervous structures. So for me, I honestly don't know. Yeah. Let's imagine somebody has a deviation to the right and he does a flexion and the deviation disappears. Whoa. Or somebody doesn't have a deviation in standing, he does a flexion and the deviation appears. This is so nice to see, but just one little detail. When you ask the patient to do a flexion in standing, then make sure you stand behind the patient when he does the flexion. Because when you stand behind the patient, then you can see any lateral shifts. Let's imagine you would stand lateral to the patient, then you don't see anything. Just a little practical trick. Somebody is asking in the chat, what is the meaning of derangement? Well, internal derangement in the spine. This is, let's say, a possible symptomatic discodural conflict, a disc protrusion, a disc bulging with pressure against the dura or with pressure against a nerve root. Okay, so that's our definition of an internal derangement. But you know what my favorite deviation is? There's also what we call a painful arc deviation, and I really love that. The patient is standing. He doesn't have a deviation. He's doing a flexion, and what happens somewhere in the middle of the flexion, there's some kind of momentary deviation, and then he continues his flexion. A kind of painful arc deviation. This is so nice. Yeah. This is also an element. So if you find that this painful arc deviation, this is typical for an internal derangement, and it's not going to be such a big derangement. This is, from all deviations, this is, let's say, the most favorable deviation. Okay. So far so good. A lot of practical information to put in your random access memory. So when you downloaded this lumbar spine checklist, then you're going to see later on that this could be useful to summarize some things we discussed today. Okay. And as promised, a few words about some important elements in a functional examination, but allow me to get some fluid first. Whatever test we do, before you do any test with the patient, always ask what you feel now. Is there any pain at rest? And if the patient feels something at rest, then the question is where? And then you can do a test, or the patient is doing some test movement, and then you don't ask to the patient, does it hurt? That's not the best question. You better ask to the patient, does that change anything? And then the patient can say, yeah, it hurts more, or it hurts less, or it doesn't change anything. And if it hurts more, where does it hurt more? Those are little practical details, but I noticed that, okay, during my travels, that those details are so often forgotten, and they are really so important. Yaya is asking, I hope I pronounce your name correctly, the patient has bilateral buttock pain diagnosed as facet joint arthritis. What can be done? Epidural injections did not help much. Yes. First of all, bilateral buttock pain. What is that? That's multisegmental pain. Huh? You need to be lucky to have a symptomatic facet joint problem and then a bilateral problem. You need to be very lucky. I honestly think that the facet joints in the lumbar spine are the most overrated joints in this area. A real symptomatic facet joint problem is not frequent. More about that a little bit later in the webinar. So I don't expect that this is causing bilateral buttock pain. This is multisegmental pain. Yeah. So facet joint arthritis is, in my opinion, extremely rare. Yeah? An epidural injection did not help much. That's quite possible. But then the question is, and now I go a little bit further, the question is, Where? Is it a traditional epidural in between two vertebrae on a specific level? Or is it the Syriax epidural through the hiatus sacralis? And those are two different worlds. Well, allow me to say something more about that. I'm going to put my screen big again. Yeah. When people get an epidural, also in the hospitals around here, mostly it's something like this. And why do they decide to give an epidural over there? Because they saw medical imaging, there's a big protrusion over there. Well, we go there. Yeah. But it's quite possible you see a big protrusion L4, L5, or L5S1, whatever. And there is a smaller problem, L3, L4, but that the smaller one is symptomatic and that the bigger one is not symptomatic. This is quite possible. So if you do a so-called specific epidural, yeah, you need to be lucky. Syriax always did epidurals through the hiatus sacralis. And then the question is, how much fluid is a therapist using? If we give an epidural there, then I don't care if there's an internal derangement here, there. I don't care, because the fluid goes in the spinal canal until more or less L2. So you cover the whole area. So yes, it's possible that the patient doesn't react on an epidural injection. Yes, it's possible. Yeah. Okay. Okay. A few test movements. Remember, I say to the patient, what do you feel now? Where do you feel it? Okay, give me an extension. Go as far as you can. Does that change anything? And then the patient says, yes, it hurts more. Don't automatically assume it hurts more in the back. It's quite possible that during extension, we produce pain in the leg. Or if there is already pain in the leg, that the pain in the leg gets worse. And this is, of course, a peripheralization. We don't like that. Yeah. So keep in mind, this is super important. I would like to see some side flexions. I would like to see a flexion, and keep in mind, stand behind your patient. Then you can see if there is any deviation, if something happens over there. And super important, motivate your patient. There's one word you can always use with your patient when he's doing some movement, and this word is further, further, further. If you ask the patient to do a flexion and he has some pain, he's going to stop at the first pain, which is logical, of course. And then he comes back immediately. No. Go to flexion again and try to go further, 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 further. Motivate the patient to go further, because we can discover some very interesting things. Wait and see. And when you reach, or when the patient is reaching his maximum, then you ask for an accessory neck flexion. And this is also going to be pretty interesting a little bit later on. But the first question I ask myself, just after those movements, which pattern did I see? And for those of you who already did a training program in orthopedic medicine in the extremities, then you know that we talk about capsular pattern and non-capsular pattern. In the spine, that doesn't exist. The spine is something totally different. In the spine, we describe two different patterns. The full articular pattern, which is a little bit the equivalent of the capsular pattern in the extremities, and the partial articular pattern. But of course, at this moment, that's probably Chinese for you. So I have to explain that. What is a full articular pattern? Well, extension and side flexions are equally limited, and flexion is the best movement. This pattern we call the full articular pattern. Check it if you have the pleasure of having grandparents, and let's imagine Your grandmother is 85 years old. Ask her today, check her extension, check her side flexions. Her extension is not going to be that much anymore. But what do you see when she does flexion? Many of those elderly ladies, they are very proud and say, hey, look how deep I can go. Yeah, this is the full articular pattern. What is the partial articular pattern? Well, that's very simple. Everything which is not a full articular pattern. So if it doesn't correspond with the full, any other combination is a partial articular pattern. Okay? In the meantime, I'm going to have a look at the chat again. I have a unilateral low back pain all the time, but once in a while it gets worse during the night by being a sharp pain. It hurts in every position and even in rest. I also have a minor scoliosis in the lumbar area. Is it possible that I experienced this because of the scoliosis? Then, of course, I don't know your complete story. Of course, I didn't do a functional examination with you, but just based on what you share with us here, I clearly say no. No. A scoliosis, even a minor scoliosis, is not causing such symptoms. So we have to look in a different direction. Another question, is there a difference between extension with and without hands in the back? Why would you choose one over the other? That's a nice question. Let me go back to the previous pictures here. Yeah. Actually, for me, both of them are as good. I just want that the patient goes as far as he can. But later, when we talk about prevention, and when perhaps he gets an extension exercise program, then I notice that putting the hands in the back, that facilitates this a little bit. It's easier for the patient. Yeah? Okay? Good. So we come back to full articular pattern and partial articular pattern. If you find a full articular pattern, what is the clinical interpretation? Well, that's arthrosis, arthritis. If you find a partial articular pattern, that could be a disc, that could be an internal derangement. Yeah. Could be other things also. Huh? Facet problem is also going to cause a partial articular pattern, some muscular problems. Yeah? But if we reverse the situation, internal derangement is always a partial articular pattern. So if somebody has a symptomatic discodural or a symptomatic discoradicular conflict, you always find a partial articular pattern. Always. Yeah? That's also nice to know. Okay. Leah is asking, the PDF file is not downloadable. Normally it should be there. It's open. I see it on my screen here, so you just have to click on it, and normally it's going to open on your computer. Yeah? Okay. If you would experience problems, just send me an email. Yeah. And to make life easy, if you send an email to this email address, then you're talking directly to me, okay? To info@syriax.eu. Okay, well, you know what the beauty is? Let's imagine you find a partial articular pattern, okay? And you find the painful arc on flexion. And this is the reason why I said to you, if a patient is doing a flexion, motivate the patient to go as far as he can. Don't be satisfied too early. Come on, further. Yeah? So if you find a combination of a partial articular pattern and a painful arc, I love it. This must be an internal derangement. It must be a small internal derangement. In other words, very easy reducible. How you reduce it, by some manipulation technique, traction technique, exercise, I don't care, as long as we reduce it. And certainly the problem has no psychogenic nature. Psychogenic patients don't know painful arcs. Okay, this is something we see quite often. So you notice that what we did until now, I didn't need those ones too much. Huh? It's just opening your eyes and your ears. Huh? Yeah, but okay. I just mentioned that the facet problem is probably the most overrated problem in this area, but okay, it's possible. So keep in mind, facet joints are unilateral structures, only cause unilateral pain, okay? No shifting pain. So in the history, you don't hear a shifting pain. It started unilateral, it stays unilateral, there is not too much radiation, yeah? And you don't have dural signs. In other words, when we do a straight leg raise, and I'll show you that a little bit later on, straight leg raise is going to be negative. And when we come back to the flexion, remember, one of our tests in standing, I mentioned to you, we go as far as possible in flexion, we go to the end, and then we ask to the patient to do an accessory neck flexion. Hey, let's imagine somebody has unilateral paravertebral pain. Flexion is painful. Could be facet. But then at the end of the flexion, you ask for an accessory neck flexion. And what does the patient say? Oh, I get more pain. Where? Oh, unilateral, in my back there. Or he says, I get less pain. So on doing neck flexion, you get more or less unilateral paravertebral pain. I love it. This is a discodural conflict. And this is with certainty not a facet joint. Okay? So that's why I emphasize it again. Ask your patient to move as far as he can. Okay? Facet lesions are also not going to cause dural symptoms. When you registered for this webinar, you had the opportunity to fill in a question, and the question was, if you have lumbar pain on coughing, could that be a facet joint dysfunction? Yes or no? Well, about 146 people, I think, answered the question, and about 65% said no, it is not, and you're right. Yeah. If a patient has lumbar pain on coughing and sneezing, this is again a dural symptom and is not related with facet joint. Another little thing from the history, so many lumbar patients, they say, okay, we don't like to sit too much. Yeah. Or some patients say, yeah, okay, I don't have too many problems on sitting, but when I stand up, then I have a problem. And what is that? This is what we call, the curve reversal. Yeah, they are sitting, mostly they are sitting in some kind of slouched position. Yeah, and then they go from the transition from kyphosis, standing up, towards a normal lordotic position. And this transition with internal derangement patients is very often problematic. So, with facet joint patients, doesn't matter. No? Okay. So you already have now quite a lot of, let's say, information, quite a lot of details from the history and the inspection, which can help you to determine your diagnosis. And then we continue with the straight leg raise. Little detail, always do it in a passive way, okay? Never do it in an active way. Active way, that's not the best idea. First, you do it on the good side. Yeah, because I don't want to confuse some stiffness in the hamstrings with a positive straight leg raise. Yeah. And okay, for me, for instance, I am Mr. Stiff. My straight leg raise is about 70 degrees. That's who I am. But I remember a lady of 73 years old, one of my patients, and she had a straight leg raise of 120 degrees. But she did gymnastics every day, and I don't. So there's a difference over there. But very important, you do it slowly, and at a certain moment, perhaps the patient says, "Oh," then you stop, and you ask the patient where. The patient can have back pain, the patient can have gluteal pain, the patient can have leg pain. Yeah, and then you try to go further. Okay, go further. Don't be a torturer. Yeah, but try to go further. And they say, oh. And suddenly, what do you discover? You discover a painful arc. Like we discovered a painful arc on flexion in standing. If you find a painful arc on straight leg raise, I love it again. This is again most likely related to a small internal derangement. The question came in the chat, will this webinar be recorded? Well, yes, probably. You came in a little bit later in the webinar. Yes, it is. This webinar is recorded at this moment, and you will receive the replay link in your email in an hour from now. And this replay link is valid for 1 week. Okay. Let's imagine you do a straight leg raise. Yeah. And at the end of the straight leg raise, we do an accessory neck flexion, as we did with the flexion in standing. Again, things can change. The patient can say, oops, I get more pain in my back, in the gluteal area, in the legs. The patient can say, I get less pain. Those are typical dural signs again. That points again towards internal derangement. Facet joints, muscles, sacroiliacs, they don't cause this kind of symptoms. Okay? Good. Actually, there are several stages in a straight leg raise. Yeah? My favorite stages are the first 3. A straight leg raise can be perfectly negative. Not every internal derangement causes a positive straight leg raise. It depends a little bit on the size and the location. Very, very often you see that the straight leg raise is painful end range. There's no limitation. This is super frequent. And then the painful arc. I love it. If you look at stage number 4, your straight leg raise is painful, limited, but there is no motor deficit. Well, okay, that's a little bit a bigger problem, but don't worry. If you have motor deficit, then then we have a problem. Yeah, then there is too much pressure on this nerve root. The conduction is disturbed. Then perhaps it's a better idea to send the patient back to the doctor or to the hospital and to look further. Yeah? But one thing I can already say, a monoradicular deficit is not necessarily a reason for surgery. But okay, I explain that more during the online masterclasses and the live courses. Then there are 2 more stages, but allow me to talk more about that on another occasion. In the meantime, I'm going to have a look at the chat again because you're pretty busy on the chat. Patricia is asking, can you also add dorsiflexion in the ankle while doing straight leg raise? The question is, the answer is yes. Does that change anything, or does that mean when you incorporate dorsiflexion? Well, you can do that, but I try to get as much information as possible with as less tests as possible. So if I do that, it doesn't give me extra information. It doesn't, I don't become extra wiser from it. So I have nothing against it. You can perfectly do it. But to be honest, it's not really necessary. Okay. Then another question, what about stenosis and osteophytes? How can we make the difference? Good question. But yeah, we have maximum 1 hour and a half. And if you know that my lumbar spine course takes 3 days, then, you know, I can talk a little bit more about that. But as a solution to your question, I advise you to join the online masterclass, the online toolbox. I'm going to say something about that in a few minutes from now, and do you a special offer. There you find the complete course in orthopedic medicine is online. Whenever you want it, wherever you want it. That's a very nice added value together with the live courses. So some of you who are watching the webinar here today, they are already, have access to this online masterclass. Okay. What are the good treatment options if dural sign is positive? Yes, I'm going to give you the same answer. I'm going to refer to the online masterclass and to the live courses, because we have not only we have to make a diagnosis, but then we have to set a treatment strategy. And we have quite some interesting inclusion and exclusion criteria when it comes to manipulation, mobilization, traction, exercise. So we have to create a strategy. So I refer to the online courses. Can there be only gluteal muscle pain, or would all gluteal pain be spine related? Good question. No, let's reverse the situation. Lumbar spine patients have very often radiation of pain in the gluteal area, very often. But could there be a local problem? Could there be a gluteal problem? Yes, this is also possible. And then the very first idea, the most frequent idea in that direction is some kind of bursitis. A real muscle lesion over there, like for instance a gluteus medius lesion, this is not so frequent. Yeah. Okay. Several people come to this conclusion because they take an echography and they see something on the echography, but you and me, we know that this is not always very relevant. Gluteal pain, when it is local, first idea is some kind of bursitis. But then we go to the hip course, and the hip course is also, of course, online or live. Okay. And then I promised that I would say also a few words about the sacroiliac joint. Well, it's pretty complex. You know? How can we test the sacroiliac joint in a relevant way? It would be nice if we have some tests which test the sacroiliac joint without influence on the lumbar spine and without influence on the hips. That would be great. Do we have this? No, that doesn't exist. That's one problem. And then another problem, there are two kinds of tests in the sacroiliac joint. You have on the one hand the mobility test, and on the other hand the pain provocation test. And in the introduction of today's webinar, when I said that palpation for segmental mobility is not the best idea to start your examination with, this is exactly the same when we talk about sacroiliac joints. Many people, they find some hypomobilities, but sorry, dear colleagues, the only thing I can say based on so much research, you don't see that here in my presentation, but I talk about that during the live courses. Manual mobility test for the sacroiliac joint. There's just one word for that. No, two words. David Copperfield. In other words, illusion. Okay. The good news, that's good news, but the other good news, we're going to focus on pain provocation test. I have an eye on the chat again. Patients after discectomy coming with gluteal pain, will that be local or not? Good question. Once there was surgery, the situation is always different. If a patient has pain after surgery, what's the problem? Sometimes difficult to interpret. Most likely not a gluteal local problem. No, most likely not. Yeah? Most likely it's related with scar formation, with adhesive scar formation, with irritation of free nerve endings and that kind of stuff. But we have to make a distinction between two situations. Let's imagine somebody got surgery, he's recuperating, but since the surgery, he has pain. Somebody else got surgery, whoa, very happy. And then 8 months later, bam, back pain again, or gluteal pain. Those are two different things. Yeah? Those are two different worlds. Okay. To continue on that question, the neurosurgeon insists it's muscle pain. Yes, not only the neurosurgeon. I think 95% of the doctors here in my neighborhood and in whole Belgium think that. This is, of course, a misinterpretation. Yeah. For the patient, it's not a misinterpretation. Patients are very often going to say it's this muscle there. It feels like muscle pain. But talking about pain, what I also mentioned at the beginning of this webinar, on the online masterclass, I put this extra lecture on pain. If you have the chance to watch it, to join the masterclass, do it today. Do it today, because you're going to have a lot of fun with that. But just the statement, the neurosurgeon insists it's muscle pain. Yeah, okay. It's an irrelevant statement. But yeah, you know that. Okay, which test can we do for the sacroiliac joint? Now we still have about 10 minutes left or so. Okay, we're talking about pain provocation tests. You're all familiar with this distraction test. Then resisted hip abduction. It has to be forceful. Use a lot of force. Okay. Patrick's test. Rotations in the hip. Go to the end and really provoke. Don't be too gentle. Otherwise, it's just a hip test. Then resisted abduction, axial pressure. Pressure on the iliac crest from side lying, and then Gainsland test and extension pressure on sacrum. So most likely many of you are familiar with this kind of test. And then finally Yeoman's test. Little detail, we are looking for pain provocation. I'm not feeling with my fingers there from, oh, it moves or it doesn't move enough or whatever. I don't care at all. Yeah. It's completely irrelevant. We're just looking for pain provocation, okay? But what do you do with those tests? Yeah. Well, there's one important conclusion you need to remember. There is a symptomatic sacroiliac problem if 5 of those tests are clearly positive. If with 5 of those tests you provoke unilateral gluteal pain. If you provoke central back pain, the test is not positive. Because remember what we discussed earlier, sacroiliac joint is a unilateral joint, only causes unilateral problems, so it cannot cause central back pain. So 5 of those tests provoke unilateral gluteal pain, then there could be a sacroiliac problem. I just challenge you and challenge yourself, as from today, with all the lumbar spine patients you see, just for fun, do those 12, 13 pain provocation tests. You just need 1.5 minutes to do that, and write down on a paper how many patients you see where you have 5 positive tests. And then after 6 months, you email me the result. I think you're not going to need more than this paper, yeah? But okay, don't believe me, just do it for yourself and challenge yourself. Warda is asking, is it possible that sacroiliac joint dysfunction can cause muscle shortening or pain in the lower limbs? Well, a sacroiliac arthritis, a symptomatic sacroiliac arthritis, can cause pain in the lower limbs. What I mentioned at the beginning of this webinar, it's segmental pain, mostly dermatome S1, S2, S3. So they can have pain all the way down at the posterior aspect of the leg. Yes, this is possible. Muscle shortening, I don't think so. Then Virendra is asking, facet joint is causing unilateral pain. From the functional examination, how do we interpret the side flexion? Well, then we have to come back to the pattern we saw. Yeah, remember I talked about the full articular pattern and the partial articular pattern. A facet problem, if there's a facet problem, it is going to be a partial articular pattern and not a full articular pattern. But of course, you have to exclude also those dural symptoms and those dural signs. And there are some more things which I discussed during the live courses or the online masterclass. But it is pretty rare. Okay, so slowly but surely we can conclude. Yeah, we're already busy 1 hour and 16 minutes now. It's all about patient selection. Yeah, when you decide to treat a patient, whatever treatment procedure you like to do, the first thing I think what is important is, okay, which kind of clinical image did I see here? Which kind of pattern? What did I hear in the story? What did I see in the inspection? And probably based on this data, this patient is going to react well on manipulation. This patient is going to react well on traction, on mobilization, on exercise therapy. So we're going to do a pre-selection of patients. And this is what orthopedic medicine is about. It's not about that simple manipulation maneuver. It's not about some friction massage or whatever. It's about clinical reasoning. It's about patient selection. Okay? And that's something I very much like to share with you. So, ready to implement this in your clinical practice? Perhaps with this information next Monday, when you see a lumbar spine patient, you can already recognize some things. Yeah? I hope. And of course, the question is always coming, what's next? For those of you who didn't do it yet, the clinical reasoning book, just go to cerex.eu/downloads, and there you can find a lot of downloads. Surprise. Yeah? As I told you, I'm broadcasting here from our international training center where the mastermind private training takes place. So in September, as you know, I start a new group. If you go to the website, you can download all the information. You can ask for the brochure, and there are a lot of films, testimonials from people from all over the world who already were my guests. Just inspire yourself, okay? But I would like to conclude with something I promised to you. I said at the beginning of the webinar, I'm going to do a special offer for you. Those of you who already joined the online masterclass, who have access to the online toolbox, they already know what I'm going to say now. Yeah, but those of you who didn't join yet, well, allow me, let's say a little 5 minutes, and let's see what I can do for you. The complete course. The complete course in orthopedic medicine, we have it in an online toolbox, which is available for you 24/7, wherever you want, whenever you want it. You just go to orthopedicmedicine.eu, and you also have access to a free course. You just make an account over there and you get the 7 lessons discovery course. This is already a few hours of film, which can inspire you about the knee, about the shoulder, about the cervical spine, a lot of different things. Everything is also available through special app on your smartphone, making life easy. It's structured in such a way that when you're busy in your clinic and you say, oh, I have to treat this infraspinatus here, how exactly do I have to do that? Well, you just go to the app and within a few clicks, you see all the practical details. So if you want, you can join the Ultimate Toolbox. And what is the Ultimate Toolbox? Well, actually, I already produced a lot of books and a lot of films. Everything is online. More than 35 hours of film about clinical reasoning, diagnosis, therapy, upper extremity, lower extremity, the spine. Everything is online. Actually, this is the complete course content of 10 course days. Yeah? And Torsten is asking, I already use the toolbox. Thank you, Torsten. Is it limited to a certain date? Yes, it depends when you started. I would have to look up for your specific file. But the people who start now or who started some months ago, you have 1 year, 1 full year, unlimited access to the complete content. And many people after 1 year are so motivated and they say, yeah, I continue. I want an extra year. Just go to our YouTube channel, have a look at some testimonials. Many people already have fun with that. So it would be a pity for those of you who didn't join yet that you don't have access to this toolbox. Okay. So what do I offer you? 1 year unlimited access instead of 90 days. Yeah, the basic package is 90 days. You get 1 year access. Okay. You pay with your credit card. Your credit card is not going to be charged automatically again after 1 year. No, you just pay once. And after 1 year, everything automatically stops. Yeah? Okay. You may be sure about that. You get 1 year, all the updates, plus all the webinar recordings. For instance, the recording of this webinar also comes on the online toolbox. And my 10 previous webinars are also there. Yeah. You have the easy access through the app on your smartphone. It's really very practical. There is no advertisement. Yeah, it's not YouTube. Yeah? On YouTube, you have a lot of advertisement, but on this platform, of course, not. And everything within finger reach, so to speak. You get also more than 500 pages of well-illustrated handouts. Yeah, everything on PDF. Just download, and they are on your computer. Just a real complete package. And on top of that, I give you 1 hour of personal consulting. So we make an appointment, 1 hour together, Skype, WhatsApp, whatever, and I help you in your study process. That's a little bit the purpose. And for those of you who sign in and who say, later, I would like to join the Mastermind private training program I was talking about here in the training center. Well, for those of you who do that, you get 100% full refund of what you paid for the online masterclass. So that's also a nice deal. And now we're going to talk about the money. So the normal price is 995 euro, but because you are here with me today, and this is an offer which is valid for 1 week, but I wouldn't postpone too much because after 1 week it's finito. You just pay 377 euro for the content of 10 full course days. So that's, I think, a pretty interesting offer. And to make life easy for you, Well, if you look at the right side of your screen, then you're going to see that something appears. You just click on the link you see there, and you activate your discount code YES, and then automatically you're going to have immediate access to the complete online toolbox. You also get an official invoice in your mailbox, everything perfectly for your administration. So yeah, I would say don't postpone too much, just click on the link and give yourself a pleasure. You're going to come to this page. You just click on the upgrade box so that you have 1 year access instead of 90 days. Then you fill in the discount code YES, you click on the arrow, and automatically you're going to see that the price is changing in 377 instead of 995, and you can go ahead with it. So there are many good reasons to join the program together with me, and so many other colleagues who already did. So this is slowly but surely the end of the program for today. But in the meantime, I'm going to have a look at the chat again. And Luc is asking, you didn't say anything about secondary or tertiary prevention. Is treatment useful if the patient continues his wrong movements? For example, being bending forward to put off his shoes, as you say in the beginning, etc. Of course, Luc, you're completely, yeah, I totally agree with you. We have 1 hour and a half today. This is a separate part of the online program and the live courses. I even created new back instruction cards for my patients. You can send me an email privately. I can tell you more about that, because this preventive part is not important. It's super important. And of course, as long as the patient doesn't take care of the important preventive elements, I can keep on treating, but that's not the purpose. Yeah, the purpose should be that the patient becomes treatment independent as soon as possible. So this is one of our very important tasks. Yeah, we can do some nice work over there. And Stefan is saying, I can guarantee if you take the online course or mastermind course, then all puzzle pieces come into place. I work in a modern rehabilitation in Ostend, and this gave me the basis of all diagnostics and treatment, and you learn to link different regions with each other. Thank you, Stephen, for giving me this good start to my career, Stefan. Thank you very much, Stefan. I appreciate that very much. I look forward to seeing you again, because it's a long time ago that we met each other live. So we have to arrange something, but thank you so much for your kind feedback. Okay, so this is the end of our story today. I have one more question. Do you have any more questions for me? I just look at the chat, because there's always a delay between when you type the question and I receive it here. I did not find the date for the training course in September. It's from 7 to 13 September. Yeah, you can, Torsten, just send me an email, yeah, info@ceriax.eu, and I will mail you today all the information. Okay, so 7 to 13 September. Any further questions? So in that case, thank you very much for joining this time, for spending your time with me, for joining this webinar. I hope it was interesting for you. Thank you very much for your kind feedback, because to be honest, it's your feedback that keeps me going. Thanks to you, thanks to your motivation, that I still have the drive to do what I do. So enjoy your weekend, enjoy your Saturday, and don't forget to have a look at your lumbar spine checklist. So thank you very much. We're going to conclude. All the best, and see you on the next occasion. Thank you. Bye-bye.